So I wanted to talk next about, we're sort of tasked with talking about trials. What about observational research, or this non-interventional trials? And I wanted to talk about 3 studies. The first is the NF2 Schwannomatosis, related Schwannomatosis natural history study at the NIH, which in its first instantiation was run by Dr. Astagiri and is now by Dr. Chittabuena. And I know multiple people, right, have said that they or their loved one is in this study. You and someone else, yes. Okay, great. So maybe you guys can chime in about what it's been like for you. What is the point of this? And what is this natural history today? I promise we get into. So this actually study began quite some time ago. Its first instantiation, which enrolled 169 people, followed them every 6 months for 5 years. And I believe this was like back in like 2000, so like a long time ago. And now has been reopened to enrollment for an additional 100 people who are going to be followed once a year for 10 years. And one of the reasons this is important, you can say, like, why do we have to enroll more people? That in some ways, what the natural history of NF2 has changed is it's changed so radically from 2000 to now. If we think about what kind of surgeries were people getting, there was no options for bevacizumab, chemotherapy there. And so natural history is kind of this misnomer. It makes it sound like people who have had nothing happen, which is not true. We don't prevent people on a natural history. We don't say you can't get surgery that you need because you're in our study. They get whatever kind of current standards of care are. And that's really radically changed for people with NF2. Also thinking about like ABIs and cochlear implants and how much they've advanced. So that's part of the reason why what we learned in 2000s was super helpful for understanding how do tumors grow, how fast do they grow, but wasn't a great counterexample for using like what's the standard now that our new drugs should be beating. And so that's why it's kind of reopened. It's NF2 at NIH.gov. They're actively recruiting. If you're interested, you can talk to them. What actually happens if you're enrolled? I think some of these folks can probably talk even better than me. It's pretty comprehensive. Imaging, surveys, blood tests, clinical assessments from everything from audiology, so how are you hearing, speech and swallow evaluations, how is that functioning, nerve conduction tests. The awesome part about the NIH is that all travel and lodging and testing is free of cost. That is not the case for a lot of medical studies at other places, but NIH as a government-funded institution is really awesome about providing all of the costs for travel. So this is one. The time commitment, as we heard, is still a lot, but at least money-wise, they can make the travel possible, which doesn't happen. And what kind of questions can you answer with a natural history? Like, why are we giving people these nerve conduction tests every year and these speech and swallow things? So I thought this was interesting to see what are the even aims of the study. There is the primary objective, what's this natural history? What's the natural clinical and radiographic progression of tumors? How fast are they growing? Is there some way to predict that? That was interesting, but there's a lot of secondary kind of questions we can answer about NF2. What are the underlying causes of speech and swallowing problems, and how do those progress? Because in the original, some of the data they saw is that it wasn't necessarily people with the biggest tumors who were having the speech and swallowing problem. So it didn't seem to be if it's not a one-to-one correlation to the tumors causing it, what is causing it and what's making it worse? To identify imaging biomarkers of hearing loss. Are there things we could see on imaging that could predict hearing losses? And I'll show you that result in a second. Can we see why are people having peripheral neuropathy? So that neuropathy, which you might feel is like tingling or numbness, kind of that nerve damage, that also we found is not a one-to-one correlation with if you have a tumor there or the tumor is big and growing. So can we figure out what is it if it's not this tumor size? And to try and find blood biomarkers of disease progression. So can we see early on when things are happening? And so here's one piece of this that was already published a few years ago from the original natural history study. And what we found out just from following people who weren't getting any special treatment, but they found that something called intralabyrinthine protein in your ear. So the labyrinth is this like, where's my pointer? The labyrinth is up. on the other screen, I'm trying to see how are these screens connected. Unclear. Oh, because this mouse is to the desktop, that's why. Let's go back. Here's the actual laptop mouse. The labyrinth here, so this is part of your inner ear. These are your semicircular canals. Here's the labyrinth. And here's one that kind of looks normal. There's clear fluid, but there's also sometimes with people with the tumors, it builds up this protein inside. So that's intralabyrinthian protein in the labyrinth. And they found out that you could see this actually on people's MRIs with a special kind of MRI sequence that's called the flare signal, just a type of MRI setting. And by looking at people and following over time and seeing who actually did develop hearing loss and when, they could look back at their MRIs and say, is there anything that was different in the people who were about to lose hearing loss in the next year? And so they saw that there are these higher levels of this protein when the cochlear aperture, so there's just a part of that inner ear machinery, was being blocked by the vestibular schwannoma, and that was correlated with who was going to lose hearing. And so you can think of that this kind of information is helpful because we often don't know when to start treatment with something like Avastin, right? We often now wait until you've already started losing your hearing and then you start. But if we could do a better job at predicting and say, hey, I think you're the person, you're gonna, this is the time, maybe that's the candidate for gene therapy. You know, we don't want to have risks and treat people when they don't need it, especially knowing that Avastin does have some side effects that build up over time, that your kidney can be kind of damaged. We don't want to start too soon, but could we start just in time if we had these kind of imaging biomarkers? So this is one line of research that people are kind of trying to continue. Can we use these imaging or blood tests that look at these kind of protein levels to see who's going to have hearing loss? So that's just the one example I have. The current study is ongoing, so I'm sorry I don't have more current results to show. But if anyone's interested, I borrowed this slide from Dr. Chidoboyna. This is the whole team at the NIH at his neurosurgery branch and his team if you would like to get in touch. And I wonder, knowing that there are some folks here who've participated, what has your experience been?
Well, first I want to say is, sure.
Just for the recording.
Yes, right. All right, so we've been doing it for, pardon me. We've been in person, I think, 3 times now. This year, we are not going to do in person because we're busy with you guys in Boston. It's been a really good experience for the most part. Like Dr. Merker said, everything is paid for. They've always been really good about working around our schedule as well, as long as you give them a heads up. I mean, the way I found out about it was basically through other people in the NF2 community. Super easy to apply. I didn't apply the right word. I don't even know. I emailed somebody, they got right back to me, and off we went. I think an important thing, and you just showed that slide about the flare signal, they don't just keep that to themselves. So, in other words, it's not just academic. A couple of years ago, they said Max was showing evidence of that protein. This might mean we're here now, maybe we're not, but there's some research, and they gave me the research too. They gave me those papers, as well as recommended a surgery, which we didn't do. We wanted to go a different way. So I guess what I'm trying to say is that it's not just hands off, like they're just collecting samples from you. They will act if they feel that intervention is necessary. They're going to recommend it, I think, for the most part. Yeah. And then you can discuss that with your primary NF2 specialist.
I was also shocked. I didn't even know they did surgery there. Like, I knew they did surgery if it was part of the study, but I was thinking for a natural history study, they must send you back to your normal, which you can go to your regular physician for surgery, but they actually could do surgery there and operate and have the tissue, which was a surprise even to me. I didn't know that was part of the capabilities of this long-term follow-up.
I'm not entirely sure, but I think they'll anything. I mean, we do see a neuro-oncologist there too. I don't know if they would do Avastin, because you wouldn't go to Bethesda if you live in Chicago and do an Avastin treatment. You're going to do that locally. But yeah, I'm pretty sure that they would do the surgery, at least in Max's case. Yeah. So yeah, I'd say overall it's been a really positive experience. And I honestly, as a parent, this is all new for me. I'm 51. This is basically a tenth of my life. It feels lots crammed in there, learning-wise, right? I've learned a lot being there too. So I'm sounding a little bit like a shill, but really, it's been a really positive experience for us.
I was just going to add, Adam shared that he learned about it in the community. I learned about it last year from Adam and from meeting Christy, who's the coordinator now. He talked a little bit about the qualitative or the quantitative experience, or the technical experience from a qualitative standpoint. It was a really great experience. I don't know if our experience was a little bit different. My son Anders didn't do some of the testing that I've heard you talk about, Adam. But it is a jam-packed. You're not going there for a tour. You're not going to see anything other than on the shuttle bus. You get to wave, at the obelisk as you drive by. But you are every single day. It was. You get the lunches, you sign up for the little lunch program, so you get to pick your lunches at the beginning of the week if you enroll, because they run out. And then they deliver them, and you'll be very happy if you get a hot meal, because you're up at the clinic.
Yeah.
So, but that said too, we found out this time you can stay at the Children's Inn until you're like 26 or something, and he can bring whoever he wants as his, caretaker or whatever. But also, because all of those people, my son said, oh, I'm like a human lab rat, just, waiting in line for them to poke and prod at me. But everybody there is in that same experience. So, even if you're not having the same, if you're not there for the same thing, you're seeing the same people. It's a really cool experience staying at the inn, because there are people from all over the world there, and everybody's in the same boat. They have some crazy thing that's being studied. So it was an excellent experience, if tiring, but still really good.
Yeah, that's the trade-off I think we make. There's so much to learn. But that list of, if we want to maximize, if you're here and we have all these things we can correlate and compare, it's amazing, but also it's tiring to have to go through all of that, even if it's once a year. So the trade-off, we really appreciate people's time, because it is not a small commitment to participate in these. But I'm glad to hear that you guys have had a good experience. And it's such an interesting hospital. It's like the only hospital in the world where everybody is, well, not maybe the world, but in the US that I know of, where everyone is in a research study in some capacity. You can't just, if you were in a car accident, they wouldn't take you there. You go somewhere else. Everybody there is in there for research. Okay, cool. How are we doing on time? Okay, 15 plus 3 minutes, 18 minutes. Also, feel free to stop. I don't need this mic. What am I doing? I have this mic. Another thing I want to talk about, having talked about interviews, this is what I do as part of the Intuit NF2 clinical trials. I wanted to talk about it and kind of what's the value of these interviews, what are we learning from them. So this was actually a grant I got from the Children's Tumor Foundation to kind of do a pilot study of qualitative interviewing embedded within clinical trials, to talk to people in trials, which has been done outside of NF, but actually hadn't been done in NF. In these trials before. So this is all part of the same Intuit NF2 trial, the brigatinib trial we talked about. And as part of this study, we actually do virtual interviews over Zoom with people who are in the trial. And we've so far interviewed 26 people. So we actually have interviewed both people who have been taking brigatinib and some who have been taking neratinib, and a mix of times. Some folks we interviewed at the very start of treatment, some folks about 6 months in, and some people about 1 year in. And we asked them for this particular, we asked them a lot of things. There was actually many objectives to this study, but the one I was going to focus on today is asking them kind of about their perspective about whether treatment was working. So asking kind of why did you join the trial, what were you looking for, and now that you're either 6 months or a year into treatment, how is it going? Are you satisfied with how it's going? What do you wish was happening? And we go through what everybody says, so we take these like transcripts, right, the written out version of what everyone says, and we start to categorize and compare what everyone's experience is to come up with kind of larger patterns about what we think is going on. And this was something that we hadn't exactly planned to study, but I found really interesting. There's a concept, this is a theoretical kind of concept, the smallest worthwhile effect, or the sufficiently important difference. Like, what is the smallest amount of benefit that we have to see that would justify giving this treatment to someone, given that it has a cost, that it has side effects, that there's inconvenience, right, of doing it? What's the minimum bar from patients themselves? What's the minimum bar we have to hit to be worth pursuing this, to be worth moving this forward and giving it to other patients? And I was really struck by what people talked about. As soon as they said it, I said, oh, duh, that makes so much sense. But it's not how we design our trials. So interestingly, the way we design our trial that I said is we follow the original design, one target tumor, the one tumor we picked that was growing, and could we shrink it at least 20%? That's the primary outcome. Probably no surprise to this audience, most of the people I talked to said, I mean, yeah, that'd be great if you could shrink that one, but like I have 8 tumors and I really, like the minimum thing for me to take this is just keep them stable. Like keep me from getting worse across all of them, and that's what I care about. And that's not how our trial, right? That's not the primary endpoint. And actually, the analysis I showed where I said we looked at all 176 tumors, that was actually because of this interview study. I said, you guys, the target tumor was great, and they were always going to, be fair, they were always going to study the non-target, but the components we said that really we're not going to focus, so we're going to stay with the target tumors where the non-target tumors were, because that's how the analysis is designed, but the primary thing we're going to put forward to the community is all tumors, and it was because we heard from patients. That's what we care about. I need you to take care of all of me, not just this one ear, or that one tumor. And like I said, it's so obvious, and you're like, but it's not how the trial was designed. Not because, and I don't want to fault the investigators or clinicians for not saying that they didn't know this. There are some technical reasons that trials are designed with the outcome measures they have, because it's partially about statistically how many people do we have to enroll to show a change. So there's other considerations, but this was something we talked to patients about. And really, we're trying to figure out what is the smallest amount, and for the most part, what we heard, and I'd love to hear, please find me either now or in the break to tell me what you think about this, that having stable tumors across, especially multiple tumors, was so important, partially because it helped preserve wherever they were symptomatic-wise. It helped them avoid having to have surgery, which a lot of people had before and said was really rough recovery or had led to kind of irreversible deficits. So for as long as they could use this drug to put that off, that was a benefit. And that it really gave them a sense of hope and agency that they had. For a lot of people, were in this just watch and wait mode. We're going to scan you and there's really nothing you can do. So to be able to take this medicine, even if it wasn't, I mean, everyone would love for it to shrink/cure NF, but even if that's all it could do was keep things stable, it still felt better than watching and waiting. And this was in the setting, as long as it was convenient to take, which it was because it was oral medicine, and as long as people were having not too bad side effects. So as long as the side effects weren't so bad it was starting to impact their ability to go to school or work or socialize, this was the trade-off that they said they were willing to make. And so this is what we learned directly from interviewing patients and talking to it. And I have some quotes here. This was just a way to kind of illustrate it. People all had growing tumors beforehand, so like shrinking would be great, but actually just stabilizing was this benefit that we wanted to look at. And so this was a quote from one of the patients at NYU who said, I have bilateral vestibular schwannomas, as most NF2 patients do. Any stability or shrinkage on either of those, that would have been a personal success. But really any stability across all of them, that was the goal for me. And so this is exactly how we do this qualitative. I didn't know that before, and it was hearing this over and over that I said, oh, that makes perfect sense. This was another patient who said, I had to have multiple surgeries, including 2 brain surgeries with really difficult recoveries and rehab. my target tumor, the right vestibular schwannoma, was still growing even after surgery. They weren't able to resect all of it. I joined this trial to retard the growth of my tumor and hopefully prevent future surgeries. So that's where we really learned about this benefit. And it's actually added another analysis to the Intuit trial. We did not previously track or had not previously planned on tracking how many surgeries people had before they got treatment and how many people ended up moving to surgery. And now that's part of our clinical case report form as another way that we're hoping to show, can we actually postpone the time to surgical intervention, because we heard from patients that that was a worthwhile benefit, something we can hopefully bring to the FDA as we try to talk about approval, to be like, what are the ways that this is actually helping, folks in their day-to-day lives. So that's really what we found, is that interviews are just so valuable for many reasons. There were other things we were talking about in interviews too, but for this thing, kind of understanding what endpoints in the trial and what kind of levels of response matter to people, whether risk-benefit trade-offs make sense, from actually talking to the people experiencing those exact risk-benefit trade-offs because they're trying these new therapies for the first time. And so it really also helped us to kind of think about, maybe this model where we shrink a single target tumor, and if that one tumor grows, you're kicked off the trial. Like, maybe that's not the right model. Maybe we should have some sort of provision for where we're looking at things also that can stabilize. Of course, also wanting something that is a magic bullet that's going to kill these tumors, shrink them, get rid of them. But if we can't, what else is worthwhile to be prescribing and looking at? Any questions there? And also thank you to anyone who's done the interviews. It's been such a pleasure for me personally, I wanted to say. As a researcher, so I don't have my own clinical practice, I sit in on patient appointments sometimes at the NF clinic, but to be able to do interviews with folks is really a meaningful experience. I learned so much from you guys about what you're going through, that it's super helpful. And so I guess this is probably the last thing we'll have time for. Sorry, my Fitbit is like trying to find what time it is, and it's like, do you want to see your heart rate? And you're like, no, I just need the clock. I don't know how to get it back, never mind. I think does anyone else have the time?
3:06.
3:06, okay, perfect. This is probably the last one we can talk about that and finish. This was also actually partially the interviews and partially surveys, but work that I'm doing in collaboration with Frank Buono at Yale, who is a psychologist who also has NF2 himself, where we're going to try to develop a new quality of life measure to use in these clinical trials. And so just to get us on the same page, what is even quality of life? It is our term for kind of somebody's sense of well-being and ability to carry out activities of daily life. And you can think of it across many domains: physical issues, emotional issues, social health, as well as spiritual, work, school, kind of intellectual. It's kind of your whole sense of well-being. And why do we think measuring quality of life is important in NF2? Specifically, we really want to get information directly from people about how they feel. We have plenty of numbers. We can track how big your tumor is. We can test your hearing. But, this is one way to get information directly from people. Do you feel any better? Because really that's what you're taking this medicine for. And we really want to see, are treatments improving people's overall well-being, not just one tumor here or one symptom there, but their overall day-to-day life, is this making an impact? And this is really important also too to the FDA. When you go to approve drugs, like Andrea mentioned, for this kind of benign tumor, where if you just said the tumor shrank 20% and that's all the data you gave them, they would not approve the drug. They'd say, okay, but does that matter? You didn't get rid of it. Like, it's not going to kill them. So you have to show, in addition to that biological activity, that shrinkage, that it actually is having an effect on people's symptoms and lives. So quality of life surveys are one way that we do that. So for this project, we wanted to develop, there are some surveys, I cut this slide for time, but I'll mention it. There are a couple of surveys that already exist, but we didn't think that they worked quite well enough for clinical trial purposes. Either they were super duper long, one of them's like 180 questions, so too long to ask people to fill out all the time, every time they came to clinic. Some Some of them were a little too short, so they didn't really cover everything that mattered, and sometimes they had confusing ways that the questions were worded, and we asked patients how they understood it. They didn't quite get it. For example, one really common question you would have seen if you've ever filled out one of the existing measures asks you about anxiety and depression in one question, and some people said, well, I have anxiety but not depression, or I have depression but not anxiety, and I don't know how to answer this. Things like that, where we said, okay, I think we have room to improve, especially in this context where we're going to be giving it to people multiple times over a trial to try and show that a drug is working. And so we're going through right now it's a pretty standard process in terms of this happens for other, not just NF, there's a standard process for like how do you develop a good outcome measure. And maybe you're going to be surprised that it involves this much work and this many interviews and surveys, but we really want to get it right if we're going to invest in it. So the top is what we've actually already done. So we interviewed 16 people in a clinical trial. So this was actually also Intuit, people who were taking brigatinib. We also had interviewed them to just get a comprehensive listing of all of the symptoms and issues of NF2 that they were experiencing. We interviewed 10 clinicians who were specifically experts in NF2, and we said, as you taking care of someone with NF2 or who would be running a trial, what are the symptoms that you really think are going to matter to people and might improve with treatment? And we used that to come up, with a whole list. So based on all these interviews, I think we had 100 different items, all things that could ways that NF2 could affect people. And we said, well, 100 is too many. I'm not going to make people fill out a 100-question survey every time they come to clinic. Let's try to narrow it down. And to do that, we ended up with 58 people with NF2 related schwannomatosis who answered a survey. We put this out through the registry back in, I believe, a couple months ago, recently. So some of you might have filled it out. It was an anonymous survey, and we just asked people to rank. Here are the top ones. Can you tell us what's most important? And we used that as a process to winnow this down to a core set of, we ended up with 21 items that the most people said were important and that had these big impacts. And we then drafted what this measure was going to look like. So we had to say, what are the instructions? What are the exact wording of the questions? What are the answer choices, right? All things that have decisions that kind of impact not only how well do people understand what you're asking, but they have kind of downstream implications for the statistics of how you analyze it. So we want to make sure we get that right. And then after we did our best stab, we said, okay, we think this looks good, our team. We brought it back in interviews. They're called cognitive debriefing interviews. They're a special kind of interview where you show someone a survey and then you ask them line by line, what did you think that word meant? What did you think that question meant? How did you pick that answer? It sounds really annoying, and probably was if you're one of the people who participated. Thank you in advance. But it's so helpful for us. By making people think out loud, you get to see, oh, that's not how I meant that word. Oh, I need to pick another word. And so actually we ended up changing significantly by iterating this. We would give it to 4 people, see what they said, tweak it, give it to another 4 people. They still had some critiques, tweak it again, and do that over and over until finally there's no more critiques. And then you say, okay, I think I'm solid. And we're just finishing that right now. We're interviewing our last 2 people who hopefully are gonna say it made sense. And then hopefully we're done. We've been getting less critiques every time, so hopefully we're at that phase. And then what's coming next is that we're going to give it to a big group. We're going to hope for 200 people. So if you see a note go out about quality of life survey, that's me. Please remember this face and how you like this face and how you want to help this face, and you're going to fill it out. Because we need to show that this is valid, to kind of have that evidence to bring to the FDA to say, this is measuring what we think it's supposed to measure and measures it well and accurately. This is the next step. You give the measure that you're developing and you compare it to some of the existing measures and you see how it is. So that's some of the evidence we bring to the FDA to say, this works. We also give it to people. We'll give it to you once, and then in 2 weeks we'll give it you again. Hopefully in 2 weeks your quality of life is not drastically altered, and so the numbers should be kind of similar. And that's the one where we say it's reliable. It's, you know, it's not like people are randomly picking numbers and it changes all over the place. It's reliable when quality of life is the same, And it's changing when quality of life is changing. And that last point we'll prove by adding it back into the Intuit NF2 trial. So there's also one quality of life survey that's already in there, which we'll keep. We'll add this one back in, and then we'll compare them. And the proof will be in the pudding. We'll see which one is showing the changes over time and can provide that better evidence. So just to show you a little bit about, oh, I guess we only have 1 minute, but I'm happy to share this. This was some of the information from the interviews. So this was the most commonly mentioned or kind of as important concepts for us to consider. And you can see we split them this way into physical, emotional, and social domains. So stuff that's probably not shocking to you that would come up, but made it clear, what kind of topics we have to cover. This is not in the measure, this medical care, but we wanted to highlight it as something that matters to folks. A lot of people brought up, again, this topic of surgeries, like I mentioned before, that's a real impact on people's quality of life, and a lot of anxiety about this medical care and scans and that happening. So that's not something that's in our measure, but we wanted to highlight it as something that's impacting people's quality of life. And just to give you an example of kind of what kind of things we were looking at, these are 2 symptoms of NF2 that are not assessed in the current measure. So they're not something that's in the current survey that people are filling out, but that people brought up as being important, and kind of what impact it had on their life. So one person told us about their vocal cord paralysis, and how that impacted their swallowing and choking, and also they had a hoarse voice, none of which is currently in the current measure. Not in the one that's currently used day to day in clinic. It is in our measure now. And same thing with hand weakness. Someone who talked about having trouble tying their shoes because their left hand doesn't quite work the same way their right hand is. And the effect downstream kind of this had, not just on being able to zip something up or tie a shoe, but having to depend on others to do some of those tasks that can really affect them. So this is the kind of information we took from interviews, and then once you have that, we said, okay, then this is how we're going to phrase the question. We're going to ask one about feeling dependent on others. We're going to ask one about using your hands and doing fine motor skills. So it's really directly from what we hear from folks that makes the measure. And yeah, this is just the last slide I have, which is we're right now wrapping up those 16 interviews like I talked about, and we made sure that we're going to cover physical and emotional and social issues, make sure we're covering the full gamut of what matters. And coming soon, hopefully in the next 1 to 2 months, we'll be doing this survey to test it out, see if it's valid and reliable. So if you see that coming out, we'll distribute it through NF Midwest. We appreciate your time filling it out. And we'll see, hopefully that works. And if there's anything there, we'll have another opportunity to kind of refine it before we put it back in the trial. And hopefully get that really good data on whether these new drugs are having an impact in ways that matter. So I just wanted to acknowledge some of the team that's working on that in the trial and on our study, and some of our funding agencies, as well as the registry, which is how we've helped recruit patients. And that's at 3:15. Does anyone have any questions? I hope you come away that it actually matters. We are listening to you when we want you to interview and do surveys. It's super important, and even when things are small and building a better mousetrap, a better tool, that a lot of these, even when they're not related to trials, eventually have that downstream impact where we think it'll help enable us to get good data on clinical trials and get things approved for NF. So thank you for all of your time, and thank you to all our participants.